Hey digital diamonds, it's time for another digital gem. Let's go! Welcome back to Digital Healthcare Solutions, a healthcare network developed to equip, empower, and encourage a thriving digital healthcare nomad community. Are you keeping up with us? Did you watch our last video on E&M coding? If not, we've got you. Click the link below to review the introduction to key and contributing factors that must be considered when assigning E&M codes. In today's Diamond video, we are delving even deeper into the specifics of how and why those 3 critical key factors and 4 contributing factors impact coding skills and reporting outcomes. As everyone now understands, it is crucial that physicians and qualified healthcare professionals thoroughly document all relevant information in a patient's medical record to accurately capture a patient's history, examination, and all relevant and pertinent facts leading towards medical decision-making, in addition to all contributing factors such as counseling, coordination of care, the presenting problem, and the provider's time of service. Now, pull up a chair, and let's review each contributing factor more thoroughly. So, let's begin with a patient's medical history. To capture a patient's medical history, accurately and appropriately, there are 4 distinct categories for patient history created to distinguish the patient's pending level of care, referred to as a patient's complexity of care. The complexity level is based on the number of elements. Again, for clarity, we are referring to information that is recorded by a physician or qualified healthcare professional. These medical history categories include problem-focused, expanded problem-focused, detailed, and comprehensive. The problem-focused history captures 2 elements: a chief complaint and a brief history of the present illness or condition. Whereas the expanded problem-focused history captures the same 2 elements as the problem-focused history assessment, along with a problem-pertinent system review. And remember that a problem-pertinent system review is just a series of questions addressing each of the body systems, whether written or audibly, to uncover any signs and symptoms that the patient may be experiencing or has experienced. And then we have a detailed history, which captures a patient's chief complaint, expanded history of the present illness, the problem-pertinent system review extended to include a review of a limited number of additional systems, pertinent past, family, and/or social history directly related to the patient's problem, and yes, there's even a more granular line of patient questions referred to as comprehensive. The comprehensive inquiry seeks to uncover a chief complaint, extended history of present illness, review of systems that are directly related to the problem identified in the history of the present illness, plus a review of all additional body systems, complete past, family, and social history. Okay, that was a mouthful. But let's drill down even further surrounding obtaining and understanding a patient's history. Each history classification consists of all or just some of the following elements: the chief complaint, a history of present illness, a review of systems, and past, family, and/or social history. The chief complaint is a brief statement that describes the reason for the patient's visit, such as a symptom, problem, condition, or diagnosis. The history of present illness is a chronological description of the patient's developing problem or condition, starting from the first sign or symptom up to the present. There are 2 types of history of present illnesses, also referred to as HPI. There is a brief HPI and an extended HPI. A brief HPI encompasses 1 to 3 elements and may involve a single problem without any complicating factors or symptoms. Whereas an extended HPI includes 4 or more elements and is appropriate for complex or confusing symptoms, prolonged development, and when a patient's history is obtained from someone other than the patient themselves. Okay, pop quiz. Are you ready? If the documentation includes 3 HPI elements such as duration, associated signs, and timing, what type of HPI would this be? Did you get it? Outstanding! It would be considered a brief HPI. Remember, a brief HPI, history of present illnesses, encompasses 1 to 3 elements and may involve a single problem without any complicating factors or symptoms. Alright, now let's revisit the review of systems. Physicians may use a variety of ways to obtain a review of systems, also shortened and referred to as ROS, to identify any signs or symptoms that the patient may have experienced or is currently experiencing. As previously stated, a review of systems is a series of questions addressing each of the body systems, whether written or audibly, to uncover any signs and symptoms that the patient may be experiencing or has experienced. Now, let's not get entangled in the non-debate over the exact number of official body systems. As a digital diamond, we read everything, and our knowledge is broad and expansive. We see that some literature references 11 body systems, some literature references 12 body systems, while some entities and medical practitioners reference 14 systems to review, while including assessing the constitutional symptoms, such as fever, weight loss, headaches, and other systems. So, what do? As digital diamonds, we read the documentation and capture the appropriate code accordingly. Okay, moving on. As we delve even further into the review of systems, yes, here comes another abbreviation, the ROS, the review of systems. We wanted to make sure we have absolute clarity surrounding the 3 types of review of systems. There's the problem-pertinent ROS, as we discussed a couple of minutes ago, when we reviewed the expanded problem-focused history. Well, the problem-pertinent ROS is directly related to any problem or problems documented in the HPI, yes, the history of present illness. Here you will see, the physician or qualified health professional will or should document any positive responses or relevant negatives for the system related to the patient problem. Next, it's the extended ROS. The extended review of system is related to the problem or problems identified in the HPI and a limited number of additional systems. Here, we should expect to see where the physician documented the patient's responses, and this could be either positive responses and/or any relevant negative responses, for about 2 to 9 systems. And then there's the complete ROS. The complete review of systems. So, the complete ROS is related to the problem or problems mentioned in the HPI and all additional body systems. Therefore, a physician will review at least 10 systems and document those systems with positive or pertinent negative responses individually. For remaining systems, a notation is then provided noting that all other systems are negative as permissible. If a notation like this is missing, the physician must document at least 10 systems individually. Are you still with us? Excellent! Because it's time for another pop quiz. This one is super tiny. Are you ready? Considering what we just discussed, can you identify the chief complaint and the review of systems? Here's our patient, Cecilia. Cecilia, a female patient, premenopausal, presents with an extended migraine headache. She has a loss of appetite and night sweats. She further denies diarrhea and vomiting. Well, what did you hear? Did you hear the chief complaint? What was it? Great job! That's correct. The chief complaint is an extended migraine headache, also classified as a chronic migraine. What about the review of systems? Let's see the patient again. Cecilia, a female patient, premenopausal, presents with an extended migraine headache. She has a loss of appetite and night sweats. She further denies diarrhea and vomiting. Did you hear the review of systems the second time? Bravo, Digital Diamonds! Excellent job! The constitutional review of systems uncovered that the patient Cecilia was experiencing a loss of appetite and night sweats. Anything else? Wow! We can't sneak anything past you. Right again! A second review of systems was documented. That's right, the second system was gastrointestinal, and we know this because the physician documented that Cecilia denies experiencing any diarrhea and vomiting. According to the documentation guidelines, we would classify this type of system review as an extended review of system because two systems were documented. Okay, moving on, let's briefly review medical decision making. So, good medical decision making involves a detailed and well-documented assessment of all the complexities associated with establishing a diagnosis and creating or selecting a patient's treatment plan. For a physician to effectively determine the number of possible diagnoses and treatment plans, the physician must consider the total number and types of problems addressed during the patient's visit, also known as an encounter. Therefore, as we can now better understand, medical decision-making is based on any number of possible factors including the assessment of data points, patient insights and/or feedback, test, and clinical observations, both present and past. So, once again, we see the importance of clear and detailed clinical documentation. Clear, concise, and yet detailed clinical documentation is truly the gateway to better patient care, treatment initiatives and/or changes, as well as physician or specialty referrals, consultations, and diagnostic testing, followed by a thorough assessment of laboratory findings, radiology reports, and/or diagnostic test results captured in the progress note or the report containing the test results. Now, let's pull all of the preceding information into context and connect this to E&M coding. Because you now better understand why thorough documentation can lead to better patient care, you now better understand why detailed documentation and the coordination of care are crucial components in determining the level of service for E&M coding. This includes discussions with the patient about diagnostic results, treatment options, and patient instructions. The E&M service codes are selected based on the category and subcategory of service, specific notes, and patient instructions. The extent of history obtained, examinations performed, and complexity of medical decision-making are also considered to determine the appropriate level of service codes. The notion of time is a separate contributing factor along with face-to-face time and unit floor time, in which we will cover in our next video. Well, that's it for now. Remember, this was just another piece of a growing digital E&M coding puzzle that we wanted to review with you. However, we think we might have one or two more tidbits to share on E&M coding, so you have to stay tuned in to see what's next. As always, we hope and trust this information will be used and shared as a valuable tool as you strive to be a digital diamond, a professional medical coder and/or biller, or even if you are starting your own billing service. But no matter what you do, remember, because you strive to be a digital diamond, you read everything, your knowledge is broad and expansive, you attract success, and you create the life that you want to live. Thank you for watching. If you enjoyed this video, Please give it a thumbs up and consider subscribing to our channel and be part of the digital healthcare nomad community. Don't forget to hit the notification bell so you never miss a new upload. Your support helps us create more great videos for you. Thank you again, and we'll see you in the next one.